Okay, today we will discuss ophthalmology MCQ. First question, all of the following ocular muscles are supplied by cranial nerve 3 except superior rectus, superior oblique, inferior rectus and medial rectus. So the answer will be superior oblique. Superior oblique. So extraocular muscles. First of all, extraocular muscles control the eye movement. Control the eye movement. Extraocular muscles control the movement of the eye, like LPS or levator palpebrae superioris. Muscle which elevates the palpebrae upwards, resulting in opening of the eye. And when LPS gets tired, Muller's muscle and frontalis muscle helps in elevation of eyelid. So eyeball has 6 muscles in total 6 muscles. 4 recti muscles, 2 oblique muscles. Superior, inferior and lateral rectus and medial rectus. So 4 rectus. Superior, inferior, medial means towards nose, medial, and lateral towards ear. Lateral. And 2 oblique muscles, superior oblique and inferior oblique. The muscles supplied by oculomotor nerve, that is third cranial nerve 3, are superior, inferior, medial rectus and inferior oblique, sphincter papillae and ciliary muscle. Lateral rectus is supplied by abducen, 6th cranial nerve, and trochlear nerve supplies superior oblique muscle. Trochlear nerve, superior oblique muscle. Supplied by 6th nerve, superior oblique muscle. Superior oblique muscle supplies by 4th nerve and all other by 3rd cranial nerve. All other by 3rd cranial nerve. Okay. So one thing to remember, that is LR6, SO4 and O3. That means lateral rectus by 6th cranial nerve, superior oblique by 4th, supplied by 4th cranial nerve, and all other muscles by 3rd cranial nerve. All other muscles by 3rd cranial nerve. Okay. Okay, next we can see the several muscles here, like superior rectus, superior rectus, lateral rectus, medial rectus, and inferior rectus. These are oblique, superior oblique and inferior oblique. And the functions are given in this And the functions are given in this next image. That is intorsion, elevation, depression, extorsion, and lateral rectus abduction, while medial rectus adduction. Okay, so these are the functions of these muscles. Okay, next question. All of the following statements are true about the ocular motor nerve. Oculomotor nerve except supplies extrinsic ocular muscle, nucleus is located in lower midbrain, nucleus is located in upper midbrain, and palsy may lead to ptosis. So the answer will be nucleus is located in the lower midbrain. So supplies extrinsic ocular muscle, oculomotor nerve. Oculomotor nerve supplies extrinsic ocular muscle. That is true. Oculomotor nerves nucleus is located in the upper midbrain. That is also true. The palsy of the oculomotor nerve lead to ptosis. That is also true. But nucleus is located in the lower midbrain. That is false. So you need to know the location of the cranial nerve. Cranial nerve 3, oculomotor nerve. Nucleus is located in the upper midbrain. Nucleus is located in the upper midbrain. This table is summarizing the cranial nerve with its with their corresponding nucleus location and also function. So oculomotor nerve, cranial nerve 3, their function is to eyeball movement, extrinsic ocular muscle, supplying the extrinsic ocular muscle and eyeball movement. And trochlear nerve, fourth nerve, its nucleus is located in the lower midbrain. And again, the same function, extrinsic ocular muscle, supplying the extrinsic ocular muscle, leading to eyeball movement. Next, abducens nerve, its nucleus is located in the pons. And eyeball movement, it controls the eyeball movements by supplying extrinsic ocular muscle again. And hypoglossal, 12th cranial nerve, hypoglossal nerve, its nucleus is located in medulla, and the function is tongue muscles and movement, supplying the tongue muscles and its movement. So these are some of the cranial nerves and the respective nucleus location and their function. So especially we need to remember the oculomotor nerve and the trochlear nerve for ophthalmology. Oculomotor nerve and trochlear nerve, their nucleus is located in upper midbrain and lower midbrain respectively, and their function is same, eyeball movements by controlling extrinsic ocular muscles. Here. These are glands. These are glands of eyelids except glands of Jay's, meibomian glands, lacrimal glands, and glands of mole. And the answer will be lacrimal glands. Okay, so let's revise the glands of eyelids. What are the glands of eyelids? First of all, we will see the name: meibomian, glands of Jay's, glands of mole, and accessory lacrimal glands of Wolfring. So meibomian glands, they are known as tarsal glands. tarsal glands, which are present in the stroma of tarsal plate and are arranged vertically. They are modified sebaceous gland. So very important to remember that they are modified sebaceous gland. Simply question can come, very direct and simple question can come like this also, which meibomian glands are which type of gland. So you need to remember modified sebaceous gland, and their ducts open at lid margin. Their secretion constitutes oily layer of tear film. Glands of Jayas, they are also sebaceous gland opening into follicles of eyelashes. Mole are also modified sweat gland, not sebaceous gland. Glands of mole, they are sweat gland and situated near the hair follicle. Open into hair follicle only, or into the Jay's gland, or into the glands of Jay's. And accessory lacrimal gland of Wolfring, they are present near the upper border of the tarsal plate. Lacrimal gland is one of the gland of lacrimal apparatus, and it's not among the eyelid gland. Lacrimal gland are not among the eyelid glands. It belongs to lacrimal apparatus. Okay. Now the point to remember. Okay, so point to remember: meibomian gland, gland of Jay's, glands of mole, and accessory lacrimal gland. Now, first of all, meibomian glands are modified sebaceous gland, and their duct open at lid margin. That is important. Their duct open at lid margin. Gland of Jay's open into follicles of eyelash. Follicles of eyelashes. Mole, they are situated near the hair follicle, open into hair follicle, or into Jay's gland, open into hair follicle, or into ducts of Jay's gland. Ducts of Jay's gland. Accessory lacrimal glands of Wolfring present near the upper border of tarsal plate. Present near the upper border of tarsal plate. So no need to there's no opening written. So these three openings are very important: meibomian, Jay's, and mole. And another thing to remember is that both of these are modified. Actually, meibomian is modified sebaceous. Modified sebaceous gland is meibomian, while Jay's is sebaceous gland. And mole is modified sweat gland. Okay, so this is about the glands of eyelids. Simple question, direct questions like this, anatomical question like Jay's gland is opening into which, okay, where its opening lies, or the glands of moles opening into hair follicle or into the duct of Jay's gland. So these kind of questions are also important. Now next question, a rod is placed in front of the one eye and the patient is asked, okay, rod is placed in front of one eye, okay, and the patient is asked to fix on a point light in the center of Maddox tangent scale. at the distance of 6 meters. The instruments that are used are shown here. Okay, so what is the test going on? Corneal topography, visual acuity test, slit lamp exam, and Maddox rod test. So this type of question will come. Sometimes it's difficult, sometimes it's easy, and they have already named one Maddox tangent scale, and you can see there written Maddox rod test. But you need to know, you must know the whole thing, what is going on, and the instruments, especially this. Okay. So in this case, the answer will be Maddox rod test only, but sometimes you need to know overall. Okay, just by matching, yeah, Maddox scale, Maddox rod test. That's not the way, because if we follow this type of strategies, then there is chances of mistakes. So we need to know the actual test, what is going on. So anyway, Maddox rod test. This is Maddox rod test. So in Maddox rod test, what happens? The rod is placed in front of the eye. The patient is asked to fix on a point light. Then Maddox rod is placed in. Then Maddox rod converts the point light image into a line. Thus, the patient will see a point light with one eye and a red line with the other eye. And due to dissimilar images of the two eyes, fusion is broken and heterophoria becomes apparent. Heterophoria means latent squint. So if the patient is squint but cannot be detected significantly or clinically, then we go for Maddox rod test. Whether the patient is really squint or not, that's called latent squint. Especially Maddox rod test, not only to detect squint, but also Maddox rod test is done for latent squint. Latent squint. So testing for vision and refractive error, examination of case of heterophoria. Okay, so due to similar, so heterophoria becomes apparent. Now Maddox wing test is there. That is used to measure phoria of near distance. Phoria means strabismus. What is strabismus? A misalignment of the visual axis of the two eyes, which in common word we call it squint. So heterophoria is known as latent strabismus, and this topic is about latent strabismus, where Maddox rod test is given. It's the condition in which eyes to deviate is kept latent by fusion. Okay, so examination of case of heterophoria. Other examinations are testing for vision and refractive error, cover and cover test, prism cover test, and the question that is asked, Maddox rod test. Maddox rod test. Another is Maddox wing test is there, which is used to measure phoria of the near distance. Okay, so next question, okay, next we have heterophoria. What is heterophoria? A condition in which tendency of the eyes to deviate is kept latent by fusion, latent squint. Therefore, when the influence of fusion is removed, the visual axis of one eye axis, okay, the visual axis of one eye and the axis of another eye deviates away. Orthophoria is a condition of perfect alignment of the eyes, of the two eyes. Okay. So orthophoria is a condition of perfect alignment of the two eyes. Now types of squints. One is latent squint or heterophoria. Another is manifest squint. Under this, committant and incommittant is there. Now types of esophoria is a tendency to converge. Now this is normal. Hypotropia or eye turns down. This is hypotropia. Hypertropia, eye turns up. Exotropia, eye turns out. Esotropia, eye turns on. On means, sorry, eye turns in. In means medial. Medial convergence. Medial deviation, okay, or convergence. We call it convergence or medial deviation. So exophoria is tendency to diverge, and esophoria is converge. So this is esotropia. This is esotropia, and this is exo. This is eso. Hyperphoria, upward. Hypophoria, downward. And cyclophoria is tendency to rotate around a axis actually, or throughout the eye. Okay. Throughout the eye. The evaluation, refraction test should be done. Uncover test which tells about the heterophoria. Then Maddox rod test should be done. Maddox wing test should be done. And as for the treatment goes, refraction occlusion therapy in the presence of amblyopia, orthoptic exercise, operative corrections, and prism correcting for remaining error that can be given. Now next is manifest squint or heterotropia. Heterotropia. This is heterotropia. So next, committant and incommittant. So committant is the amount of deviation in squinting eye remains constant. So amount of deviation in squinting eye remains constant in all the direction of gaze, or there is no limitations of ocular movement. Okay, and types is alternating squint, esotropia, exotropia, hypertropia. So all these are types of committant squint. Next, evaluation should be done as test for refraction, visual acuity, ocular motility, it should be motility, and direct cover test, alternate cover test, estimation of angle of deviation, and Hirschberg corneal reflex test. And incommittant is manifest squint in which amount of deviation varies in different direction of gaze. That is incommittant. And types is paralytic squint, A and B pattern heterotrophias, special ocular motility defect, and clinical presentation is diplopia, confusion, nausea, vertigo, ocular deviation with restriction of eye movement, and compensatory head posture and false projection and orientation, loss of stereopsis, normal visual acuity, and no amblyopia. So evaluation should be done all the tests that are done in committant, and diplopia cutting, hair screen test, force deduction test. Treatment of the cause, diplopia by occlusion and surgery if no recovery is shown in 6 months. Then we will go for surgery. Okay, shallow anterior chamber is found in myopia, phacomorphic glaucoma, aphakia, phacolytic glaucoma. And the answer will be phacomorphic glaucoma. Phacomorphic glaucoma is term used for secondary angle closure glaucoma due to lens intumescence. So basically phacomorphic is secondary angle closure glaucoma. The increase in the lens thickness from an advanced cataract or rapid intumescent lens or traumatic cataract can lead to pupillary block and angle closure. So phacomorphic glaucoma is the term used for secondary angle closure glaucoma. Secondary angle closure glaucoma. Okay. And the increase in the lens thickness from an advanced cataract. So what happens? Lens thickness increasing. Lens thickness increasing from an advanced cataract. So why is lens thickness increased? Advanced cataract occurred first. Advanced cataract occurs first, and lens thickness. And rapidly intumescent lens or traumatic cataract which can lead to pupillary block or angle closure. Okay, so deep anterior chamber is seen in young males and myopes, deep anterior chamber, and shallow is seen in children, women and elderly person. And phacomorphic glaucoma is an angle closure glaucoma caused by mature cataract making the anterior chamber shallow. So what happens in phacomorphic glaucoma? The angle closure is the angle closure glaucoma only caused by mature cataract making the anterior chamber shallow. Okay, like women means mid-aged woman or elderly person. Also children in children also we see shallow anterior, but not in adult. So remember, shallow anterior chamber should not be present in adult. In children also they are forming, that's why it's narrowed, while in case of elderly people, the lens material already get lost, and so you can think of rice and all. Think of so caused by mature cataract and mature. So angle closure glaucoma can be caused by mature cataract making the anterior chamber shallow. Okay, and in elderly people what happens? The lens material get lost. Lens material get lost with the advancement of age, and the lens become and the anterior chamber gets shallow. Not lens material, anterior chamber gets shallow with age. Okay, that's why in women, mid-aged women or elderly person we can get shallow chamber, while in the children, due to the development is not fully finished, we get shallow anterior chamber. Okay, next is phacolytic glaucoma. This is not phacolytis, CO. Phacolytic glaucoma. Phacolytic glaucoma is an open angle glaucoma. Open angle glaucoma. Open angle glaucoma caused by hypermature cataract. In which the anterior chamber is deep. By leaking the lens. So what is happening? Caused by hypermature cataract in which anterior chamber is deep. Deep anterior chamber. Deep anterior chamber. Why anterior chamber is deep? Because lens get leaked out. Lens get leaked out. And actually anterior chamber gets shallow because lens do not, just the opposite thing happen. That means lens material get deposited. Lens material get deposited. Just remember like this. This is the lens. Now this is, if this is anterior chamber. Now if lens gains some material in the elderly, what happens? Anterior chamber gets shallow. And if lens get leaks out, lens material get leaks out, then what will happen? More space in the anterior chamber. So deep anterior chamber due to leaking out of lens material, due to leaking out of lens material. Which blocks the trabecular meshwork, and treatment is cataract surgery. Okay, next is myopia. Myopia or short-sightedness is a refractive error which most commonly presents as indistinct distant vision. Which most commonly presents as indistinct distant vision in which the light rays are focused in front of retina. Now, as the maximum distance of clear vision is reduced, the far point comes nearer. And following types of myopia are axial myopia, curvatural myopia, and index myopia. Axial is eyeballs become larger. So remember one thing, very logical. If this is retina, if here if this is lens. Now if the curvature becomes more curved or larger means eyeball becomes bigger. So what happens, actually normally what happens, it gets into like this, it get converged into like on the retina. If this convergence, convergence and meeting of the 2 points of light, 2 extremes of the light converges before the retina, then it's myopia. And exactly what happens in axial myopia? Simply the eyeball becomes more bigger. So as the eyeball becomes more bigger, the light rays can get more and more space to converge. If the retina is if the eyeball is like this, then it would be on the retina, exactly on the retina. But if the eyeball becomes bigger, then what happens? The convergence is occurring before the retina, and this leads to what? Myopia. This leads to what? Myopia. And myopia, if occurs by this mechanism, then it is called axial myopia. So in this, eyeball becomes larger. In every 1 millimeter increase of the diameter of the eyeball, 1 millimeter increase diameter of the eyeball, there will be increase of 3 the actual length has 3D will increase, 3D. Okay, so this is also important. 3 diopter increase. And curvature, if the curvature becomes more, then again the convergence will be more, and it will converge with each other. The two extreme point of light will converge each other at at a place before retina, because of due to increased curvature. Okay, and index myopia, corneal curvature normal, corneal curvature is normal, refractive index is increases, more the difference, more the bending between two media. So okay, so more the distance and more the bending between two media. Basically, this occurs not due to not due to not due to refractive not due to corneal curvature or the problem of cornea, but due to the medium. Okay, next, myopics are typically called short-sighted, so all the myopics were concave lens. And aphakia. Aphakia is what? It means lens absent, right? Lens absent. Okay. Okay, next question. Accommodation is maximum in children, young male, elderly, or none. So the answer will be children. Mechanism by which we can focus the diverging rays coming from the near object on the retina in to see clearly is called accommodation. Okay, so simply said, for example, here is a chair kept. Here is a chair kept, and here we can see the moon. Here we can see the moon. Now first, if we see at the moon, obviously the focus, the lens focus should be more relaxed. Okay, the ciliary muscles should relax to decrease the curvature of lens. And if decrease the curvature of lens can be occurred, then what will happen? The focus will be far away. Far away objects, or distant object, or distant. Okay, so when suddenly from the moon our focus will come to this chair, what will happen? The light is seeing the chair, watching the chair, looking at the chair means light is coming from much nearer than the moon, and that is why as the light is coming more from the nearest source, we need to converge it more and more on the retina. So converging it on the retina for clearer view, what we need to do? We need to increase the curvature. As curvature myopia occurs, the curvature of the eyeball occurs. Now we cannot control the eyeball, we can control the lens by the ciliary muscles. We can control the lens, and in this case we will control the lens, and we will focus on this chair. So these things happens. This is accommodation. Okay. Now during this accommodation, what happens? There occurs increase in the power. Of crystalline lens due to increase in the curvature of the surface of accommodation. So now when the eye is at rest or unaccommodated, ciliary ring remains large and keeps the jonule tense. Okay. And because of jonular tension, the lens is kept compressed or fat by the capsule. Next question is direct ophthalmoscope. Direct ophthalmoscope should be selected for diagnosis of retinal detachment, subluxation of lens, ciliary body injury, vitreous hemorrhage. So the answer will be retinal detachment. Direct ophthalmoscope should be selected for the diagnosis of retinal detachment. Now, distant direct ophthalmoscope is used to idea about the ocular media and fundus should be done routinely before direct ophthalmoscopy. Equipment needed self-illuminated. Equipment needed a self-illuminated ophthalmoscope or plane with a hole in the center. It should be performed in a semi-dark room. The ophthalmoscope should be kept at a distance of 20 to 25 centimeter from the patient. 20 to 25 centimeter from the patient's eye, and normally a red reflex is seen at the pupillary area. The uses opacities in the ocular media are seen as a dark spot. The opacities in ocular media are seen as a dark spot in the red glow at pupillary area. Now the plane of the opacities can be assessed by asking the patient to move the plane from side to side while the examiner is observing the pupillary growth based on based on ocular based on parallax principle so opacities in front of the pupil. Opacities in front of the pupil move the direction of eye movement. Opacities in the pupillary plane do not move, and behind the pupillary plane moves opposite the direction of eye movement. So these are the uses of distant direct ophthalmoscopy. Okay, distant direct ophthalmoscopy. Another thing is that distant direct ophthalmoscopy should be done before direct ophthalmoscopy. Okay. So next question, next slide. To differentiate between a mole on the iris and the hole in the iris. This is also a uses of distant direct ophthalmoscopy. To oblique illumination, both appear dark, and distant direct ophthalmoscopy, a mole appears as dark, while a hole is appear as red glow is seen. To detect a retinal detachment fundus mass, both of them are visible to reflex, grayish reflex. Okay, to detect a retinal detachment or fundal mass, grayish reflex should come, and it is not possible to differentiate them in the distant ophthalmoscope. The image in the indirect in the ophthalmoscope is inverted both vertically and laterally, which means what appears as right upper quadrant is actually the left lower quadrant. Actually, the left lower quadrant. So, sorry, left lower quadrant. So, image in the indirect ophthalmoscopy is inverted both vertically as well as laterally, which means what appears as right upper quadrant is actually the left lower quadrant. Okay, because it comes inverted. The image comes inverted.